Good afternoon, everyone. My name is Dorothy Burridge, and I'm the Regional Education Coordinator with the Central East Stroke Network. And on behalf of the Central East Stroke Network, I'd like to welcome you to our webinar today on the Iwalk Toolkit, presented by Dr. Nancy Salbach. Before I turn it over to our presenter, though, I have just a couple of brief messages for you. The first is, if you haven't done so already, it would be helpful if you downloaded the Iwalk Toolkit app by going to www.iwalkassess.com, and that web address is on the slide that you should be seeing at this point in time. And the second thing is, you're welcome to submit your questions by typing them into the question section of the control panel. We will be monitoring that during the course of the presentation. So it gives me great pleasure to present Nancy Salbach today. She is a physical therapist, associate professor, and Heart and Stroke Foundation mid-career investigator in the Department of Physical Therapy at the University of Toronto. She has published more than 70 research articles and obtained over $6 million in funding. Dr. Salbach's knowledge translation research has focused on exploring the influence of facilitation and guideline implementation tools on advancing stroke rehabilitation practice and the implementation of task-oriented community exercise programs for older adults with balance and mobility limitations. Dr. Salbach has expertise with cluster randomized trials, process evaluations, systematic and scoping reviews, measurement, and multi-level modeling. She co-chairs the writing group to update the Canadian Stroke Best Practice recommendations. So it gives me great pleasure to introduce Dr. Salbach. I'll turn the screen over to her now. So thank you.
Great. Thank you, Dorothy, for the invitation to present on how the Iwalk Toolkit can improve walking assessment post-stroke. The learning objectives for today are to describe a toolkit designed to help physical therapists adopt an evidence-informed approach to using the 10-meter and the 6-minute walk tests post-stroke. And I'm also going to demonstrate the use of the Iwalk Assess app. So that's why I hope you've all had the opportunity to download the app. You can do that at any point in time. It is free. If you go to the website, the links directly to the App Store and Google Play will be there. And then finally, I'm going to summarize the benefits and challenges of using the Iwalk Toolkit post-stroke based on a study that we did at 9 hospital sites that were either in acute care, inpatient rehab, or outpatient settings. So as most of you know, more than 50% of people have difficulty walking post-stroke, and only 60% regain the ability to walk on their own. And patients, when you ask them, identify walking recovery as a primary goal. Assessment of walking using reliable and valid tools is recommended in our Canadian Stroke Best Practice recommendations. Healthcare professionals use scores on standardized assessment tools to determine the magnitude of walking limitation, to educate the patient and families, also to communicate with other members of the healthcare team. And the scores can also be used to set goals and to judge whether the patient has been responding to therapy, and also to judge readiness for discharge. You may be interested to know that not only in our Canadian stroke guideline, but also in a recently published clinical practice guideline authored by American physical therapists and sponsored by the American Physical Therapy Association, the 10-meter walk test and the 6-minute walk test are both recommended for education, clinical practice, and research across the care continuum. So the 10-meter walk test is recommended to evaluate gait speed, and the 6-minute walk test evaluates walking distance. However, even though these tests are recommended, and they've long been used in research, we surveyed 270 physical therapists a few years ago and found that use of these two tests was suboptimal in clinical practice. These physical therapists, less than 50% reported using any standardized measure to evaluate or monitor walking change. And this was particularly notable in acute care. So what the table shows you is that in the acute care setting, only 20% of therapists reported using a measure of gait speed, and 10% used the 6-minute walk test, but the levels were higher in the inpatient rehabilitation and the private practice settings. So before you go ahead and try to solve a problem in knowledge translation research, you need to understand what are the specific issues that physical therapists might be experiencing that might pose a barrier to using these 2 walk tests in clinical practice. The types of barriers that have been reported in the literature to date relate to characteristics of the therapist, the practice setting, the tests themselves, the patients, and the research literature. For example, some providers describe a lack of knowledge or skill or self-efficacy to administer the walk tests, and others are not convinced that the tests are clinically relevant. A setting issue might be that there's not enough space for the 30-meter walkway that is recommended for the 6-minute walk test. A patient issue that a lot of us have experienced is that if you have a patient with aphasia, for example, or significant motor deficits post-stroke, then it's more difficult to administer standardized assessment tools in general. And finally, for both of these tests, multiple walk test protocols and reference values, such as age and sex normative values, have been published in the stroke literature. So that makes it quite difficult for clinicians to know which protocols to use and which reference values to use. So to address these barriers, we decided to develop the Iwalk Toolkit. And the toolkit is composed of a guide, and this was a printed version and also made available electronically as a PDF file, an app, which is now called the Iwalk Assess app. And the third part of the toolkit is a YouTube video, which is an educational video showing a physical therapist doing the 2 walk tests with someone post-stroke, and it has educational content. And you can access all of the components of the toolkit at the website that we developed to highlight the app, which is the URL is at the bottom of the slide. In terms of our methods for developing the toolkit, this is just to let you know, those of you who are interested, that of course we developed the Iwalk guide based on systematic reviews, and this was part of an earlier study. And then what we did was, even though there were multiple protocols and reference values in the literature, we used criteria to develop or to select what would be the walk test protocol and the reference values that we would put into the guide. And the research team reviewed the guide at that point. And then what we did was we sent the guide out for external review. And this included academic researchers who were experts in gait assessment, as well as measurement experts. And we also had the guide reviewed by 18 physical therapists from different provinces in Canada who worked in acute care, inpatient rehab, and outpatient and home care settings. And then we started to develop the app once we knew what our specific walk test protocols and reference values were. And then once we finalized the content in the Iwalk guide, we were able to finalize the app. And similarly for the video, we could only really produce the video once we had the feedback from all of our expert reviewers. This slide is to basically tell you that we use theory. We used a knowledge translation conceptual framework called the Knowledge to Action framework. We use social cognitive theory, which relates to self-efficacy. That's a theory that I use in most of my research. So I usually incorporate strategies for therapists to improve their self-efficacy to do a certain clinical practice. And finally, of real importance to this work was a framework developed by Anna Gagliardi, who is a knowledge translation scientist at the University of Toronto, and she had published a guideline implementability framework. And this was a guidance to the features that a clinical practice guideline should have in order for it to be more adoptable or user-friendly in clinical practice, in a sense, more effective. So finally, then, I can tell you that the Iwalk guide, after all of these reviews, ended up having 7 modules. And the modules were an introduction module, a module about how to perform the test, a module about how to interpret test performance, and then how to educate and set goals, and then how to select efficacious treatments that are also recommended in our clinical practice guideline, where these treatments are known to actually improve gait speed and walking distance post-stroke. And then we had a module which was related to how to evaluate or self-evaluate your clinical practice using audit and feedback. And then we had an activity module which involved case scenarios and activities that were to help people learn how to use the app and how to use the guide and the content for clinical practice. And then we had many appendices which related to providing agendas for 3 learning sessions that we asked our different hospital sites to do. And we also had posters of reference values that you could put up in a therapy gym, and forms that were shorter versions that we thought people would want to use or be able to post and have handy in clinical practice. Now I'm going to describe different parts of the guide just to highlight to you what's in it. And as I said, all of the guide is now available in PDF files on my website. So the first thing we had in the introduction was top 10 reasons to use the 10-meter and 6-minute walk test. And this was really my attempt at a persuasive argument to use these tests. I wanted to just persuade the reader as to why these tests would be considered clinically important. And then in the module that was about how to do the 2 tests, we had diagrams and we had a protocol for each test, which were designed to facilitate walkway setup and to facilitate how to administer the tests in clinical practice. So we wanted to make it as easy as possible. Then we had the module about how to interpret performance. And this slide just shows you how to interpret gait speed as obtained by through the 10-meter walk test. So you can see on the left here, I have to be careful, you can see my mouse too. So on the left here, we have a table which presents age and sex-specific normative values for men and women separately for different decades of age. And so this was a way to be able to compare a patient's performance to what a healthy individual of the same sex and age might achieve on the 10-meter walk test. In the lower left-hand corner here, you'll see that we had a section that indicated that in Canada, the standardized walking speed to cross the street is 1.2 meters per second. However, traffic officials may lower the walking speed of a light signal to as low as 0.9 meters per second in areas where there are a lot of children, so near schools, or in areas where a lot of residents are seniors. And then in Table 2 on the right, we presented Jacqueline Perry's classification of people as household or community ambulators based on walking speed. And then finally at the bottom, we had summarized estimates of minimal detectable change and minimal clinical important difference from the literature for the 10-meter walk test. This slide shows you the information we provide in the guide about how to interpret 6-minute walk test performance. On the left, we had done a systematic review to summarize walking distances that people need to be able to achieve to walk at different kind of locations in the community. So what I always like to point out is the superstore, for example, number 14. So basically in studies, what they did was they took a meter wheel and they went through from the parking lot, from the handicap parking spot, through half of a superstore and back out, and indicated that on average, the distance was about 610 meters. So it gives the therapist an idea of just how far someone has to be able to walk to do that kind of activity. So this was an effort to make the performance more interpretable by clinicians. And then that would also allow you to educate patients in a similar way. And then at the top right is what we call a regression equation. And if you plug in age and sex, where 0 is for women and a value of 1 is for men, then the equation gives you the normative value for the 6-minute walk test. And this was developed by Kylie Hill and Dina Brooks and others. And this allows you to calculate what would be an age and sex-specific normative value for the 6-minute walk test using Canadian data. And then at the bottom here on the right, we have the definition of minimal detectable change, which, as you may recall, is the change you have to observe in your patients to know that the change is actually true change and not just error. So we provided this information in the guide to increase the clinical relevance of the test scores for both the clinician as well as the patient. This slide shows you that we had agendas included in the appendix for 3 learning sessions. And the reason why we developed this was we wanted therapists to get together and to review the Iwalk guide and also to practice the tests in order to develop their knowledge and increase their self-efficacy and their skill to do the test. Because there's nothing worse than just feeling a little bit apprehensive or lacking in confidence because you've never done something before. A lot of students now practice these tests, or at least the 6-minute walk test, in their academic training. But therapists who didn't receive that kind of training, it's helpful just to do the test once with colleagues before you go out and do it with a patient. So you can see that each session involved the first session involved reviewing the video, practicing the tests, and discussing how therapists might implement the tests in their particular hospital. And then homework was given where we just asked people to practice a test with one patient before the next session. And then in session 2, the activities were more to learn how to use the app. And in session 3, there was some role play, and it was to practice goal setting and to discuss audit and feedback moving forward. The brief URL at the top will take you to the Iwalk educational video, which is freely available on YouTube. It's 11 minutes long, and viewing the video was expected to build knowledge and self-efficacy to do the test. So, as I said before, it shows a therapist who administers each of the 2 tests with a patient who has had a stroke and has just completed inpatient rehabilitation. So it's just to show, in summary, what's involved, to make it more clear to see how one might go about doing the 2 tests. Okay, so what I'm going to do now is I'm going to show you the Iwalk Assess app. And I'll tell you first that the app was designed as well as a knowledge tool. So it does have educational content, and it was also designed to have functional tools to make it quick and easy to actually administer the test in clinical practice and then interpret test performance at the point of care. So I'm going to just switch screens so that you can see the app. So what you'll see now is what the icon looks like after you download the app. So I'll just click on it. So it is called Iwalk Assess, and this is the home menu, and you can see right away that you can select either the 10-meter walk test or the 6-minute walk test, and that under sessions, the app allows you to save your results after you finish entering information about a patient. And then at the bottom, you have links to the educational videos that are online. So I'm going to show you first the 10-meter walk test and show you that the first thing you can do in terms of educational content is view the protocol. And this also has, for example, a little diagram to show you the test setup. And then for your patient, you can go in and enter age and sex. So I'll put 78-year-old woman. And you can come out of this, or you can perform the test directly. But entering this information allows the app to generate age and sex-specific norms. Then you can see that in the menu, the 4th selection is to enter test results directly. So we put this in because we know that some therapists might not want to use the app to actually time the 10-meter walk test. They may prefer to use a stopwatch, and that's fine. So you can use a stopwatch, do the test, and then you can enter the time into the app. Before I show you how to do the test, how to time it, I'll show you the reference values at the bottom. So the reference values were the educational content. So let's say you have a student and you just want to discuss, well, what is the standard crosswalk speed in Canada? The information that is in the Iwalk guide is also here. And then this selection shows you what walking speeds classify the patient as a household or community ambulator. And all of these have a reference at the bottom, so it is an evidence-based app. The MDC gives you what we selected from the literature as the minimal detectable change value to use, and then as well with the reference. And then the normative data, which are provided by Bohannon et al., are here. And then finally, we do have based on the SIM scale, we have a scale for being able to say what level of assistance was provided during the 10-meter walk test and the 6-minute walk test. And this is really important because in our protocols, there is reliability data showing that the walk tests conducted where the therapist does provide minimal assistance, that the tests are reliable. So in our protocols, we did allow the therapist to give minimal assistance for the person to perform the test. So that's super important because a lot of therapists think that you cannot give any assistance during these tests. Now I'll show you that when you go to perform the test, it has the instructions right there, and they're actually audio recorded. And I'll start the timer. So I'll let it run to a certain amount of time that might be realistic for a person with stroke. But basically it just counts down, and there's a bit of a delay in showing you on my screen. Just so you know, it's a bit faster in real life. Okay, so then here you can click on View Report, and then this is what the report looks like for the 10-meter walk test. So first of all, it gives you the time elapsed. So this is the number of seconds that this person took. And you'll see that the information on age and sex that I entered earlier carries over to this section. If I hadn't entered it before, you could enter it right here. And then I'm just going to scroll up so you can see the results more clearly. So the results, the app will calculate for you walking speed. And this is walking speed at whatever pace the instructions were for a comfortable walking speed. So this is comfortable gait speed at 0.56 meters per second. Using Perry's classification system, this classifies the person as a limited community ambulator. And if you don't recall what that is, you can go back to the reference section and you can refresh your memory about what that means. The next item on the report tells you what the normative value for a person of the same age and sex as your patient. So the normative walking speed value for this woman at age 78, I think I put, age 78, is 1.13 meters per second. And then the app tells you that your patient, who is walking at 0.56 meters per second, is walking at 49% of the norm. So this information is important for the therapist to have, and it does allow the therapist to understand what is the magnitude of walking deficit, but you may choose or not choose to share this information with the patient. Because as we all know, some patients might be quite disheartened to be told that they are walking at just about 50% of what a healthy individual might walk. So we in our guide, and this is very important for students to understand, we did say that you'll have to, of course, use your clinical judgment, and most experienced therapists know this anyway, that you'll use your clinical judgment in terms of what information you decide to share with the patient or just to keep for your clinical documentation. The app then, after the percent of normative value, provides you with a sum of the walking speed that the patient walked at plus the minimal detectable change value. So basically what this says is that the patient has to improve to at least 0.73 meters per second to get beyond measurement error. Okay? And then after that, the app shows you what is the crosswalk speed in Canada, and it tells you what percentage of that the patient performed at. So this patient walked at 46% of the crosswalk speed of 1.2 meters per second. The app also gives you a nice little bar graph, and it doesn't work to show you on the screen, but you can turn your iPhone or your Android phone on its side, and then it allows you to see the bar graph more easily. The black bar shows you how your patient performed, and the blue bars show you the normative value for each age decade. And so again, you may or may not choose to show this to your patient. Okay, and then you can go to save the results. So here you can, the app prompts you to enter a 3-digit ID. So there are no names entered into the app, and we have a privacy policy on our website. We basically outline what the app does save and does not save, but you can enter 3 digits here. That could be just a number, or it could be initials, and click on save, and then the results will be saved in the app until you clear them. And you can go back to the home menu to see your saved results. And then you can go ahead and set goals. And to set goals, the information in the report really already gives you what you need to set goals, but this screen will again show you what is the current walking speed for the patient. It gives you the calendar. It tells you with the minimal detectable change value added, what they would have to walk at to get beyond measurement error. And then if you want to put in that you would like this person to improve by, let's say, 10%, then by entering in 10, the app tells you, or it computes what is 10% added on to their walking speed. So if you talk with your patient and you know, if you're just trying to come up with, let's say, a feasible value to improve to, then because not everybody may be able to get beyond measurement error, then you can say, okay, why don't we say we're going to aim to improve your walking speed by 10%, and then the app will give you the value of adding 10% to the patient's walking speed. Okay, so that shows you the 10-meter walk test. And now I'm going back to the home menu to show you the 6-minute walk test. So it has similar information, as you can see by this menu, and it also allows you to enter test results directly. And the difference in terms of reference values are the following. So if you select community values, it gives you the results from our systematic review of average distances that one is required to walk at different community locations. And really, as we all know, this is going to vary in cities of different size, but it just gives you a ballpark. You can also get onto a map, you know, a Google map or some kind of a map app that allows you to actually plot actual distances. If the patient tells you that he or she likes to walk to the park near their home, you can actually figure out what that distance is and use that as a guide. But if you know, for example, that they're going to need to shop on their own, then if you look at the distances needed to go to a shopping mall or a drugstore or a supermarket, it gives you a ballpark idea of what distances they should be able to walk. We also have intensity of exercise, and this is our attempt to get people to start using heart rate reserve or rating of perceived exertion to determine what level of intensity your patients are walking at. So this area is educational in that sense. And then you have the minimal detectable change for the 6-minute walk test. And then as well, you have Kylie Hill's regression equation here. And you also have regression equations for American healthy individuals as well as Australian. And this was our attempt to have the app user-friendly in these other countries that had studies where they'd had a sufficient sample size to put the values into the app. Then we have, similar to the 10-meter, the rating of the level of assistance to walk, and then also the Borg scale for rating of perceived exertion. So you can show this and have them rate their level of exertion using your phone if you prefer. So then we're going to go into the test. I have to just remind you that there are screening criteria for doing the 6-minute walk test, and the app can walk you through those things. But you do not need to, if you've already screened the individual, you can go directly to perform the test. And as you all probably know, the 6-minute walk test does have somewhat lengthy instructions, but they're all here. And if you go to the timer, we adjusted this screen with therapist feedback. Basically, therapist said, give us a big circle, a big button for indicating the number of lengths that people complete during the test. So what I've done is I've already started the 6-minute walk test, and you can see that the numbers count down from 6 minutes. And this is, by default, it assumes a 30-meter walkway because that is the recommended length of walkway. However, the app does allow you to enter a different distance, and that would be under settings, because we know that even though 30 meters is a standard, like it's a standard that we should all strive for, some hospitals simply don't have that distance. So basically, you can tap the button, and as many lengths as the person completes, you just keep tapping as they complete a length. You can see the timer is about to hit 5 minutes. There are standardized instructions that you're supposed to give to the patient each minute, and you're going to see it pop up. Your phone should vibrate, and then it shows you what you should say to the patient at 5 minutes, which is, you are doing well, you have 5 minutes to go. This will disappear after a few seconds, and it'll keep counting down. And if you make a mistake in your counting of the lengths, then you can reduce the count with the button here below the bubble. Okay, so I'm going to stop this, and I'm going to exit. And then because I haven't let the test run completely, the report is not final. But you can see that here in the report, you would enter in the length count, you would enter in the walkway length, and then the partial distance. So if I just enter that the person did 2 lengths and then did 15 on the last length, then the app will calculate for you that the total distance was 75 meters. And then you can see that age and sex carries over. And then here under the results section of the report, it gives you the normative value because it's used that regression equation from Kylie Hill and Dina Brooks and colleagues, and it's computed for you what is the normative value. It's telling you that your patient only walked 13% of that value. It adds the minimal detectable change and tells you that if you want the patient to improve beyond measurement error, they need to improve from 75 to 106 meters on this test. And then we've included information on heart rate max and also heart rate max for patients taking a beta blocker. Finally, the report tells you which community distances the person surpassed given the distance they walked in 6 minutes. And this is just, again, to give you kind of a feeling for what they're able to achieve in a community setting, understanding the limitations of these numbers. And then again, you can save the results and set goals similar to the 10-meter walk test. Okay, so I'm going to come out of the app now and take you back to the presentation. All right, so I hope you enjoyed that review of the app, and now, and if you have questions, please send them to Dorothy and colleagues. So now I'm going to tell you about what we learned when we evaluated this Iwalk Toolkit in these 9 hospitals in Ontario and Nova Scotia. So we were funded by the Canadian Institutes of Health Research to do this study, and our aim was to evaluate the effect of the Iwalk Toolkit on use of the 10-meter walk test and the 6-minute walk test by physical therapists post-stroke in acute care settings and in and outpatient rehab settings, not in the home care setting. So we did use both quantitative and qualitative methods. We had 49 physical therapists who participated, and the eligibility criteria were that they had to indicate they treated at least 10 stroke patients per year. And then as well, 7 professional leaders at these 9 hospitals also participated. There are only 7 leaders, even though there are 9 hospitals, because some of these hospitals were from, a multi-site organization. So we recruited by visiting the hospital and inviting their physical therapists to participate. And then in September of 2015, we simply provided the toolkit to the hospital sites. And in terms of the smartphone app, for therapists who did not want to use their personal phone, we actually bought Android phones and downloaded the Iwalk Assess app to the phones and gave them to the therapist. And so that's how we overcame that issue. And 5 months later, all sites reported that they had completed learning sessions. In terms of data collection, we did survey therapists before and after. We surveyed them about confidence, about their self-efficacy levels, and about their knowledge and their use of the app. But our primary outcome was actually whether they actually did these tests more often after we gave them the toolkit than before. And we determined that primarily by chart review. So we did a retrospective review of charts over an 8-month period before we gave them the toolkit and an 8-month period after they'd finished the learning sessions. And then we conducted focus groups with therapists and we interviewed the professional leaders. So all sites completed the group learning sessions, and of course, not everyone is able to attend for various reasons, for scheduling reasons. This slide shows you that 78% of the therapists attended session 1, and 61% attended session 2, and 50% reported attending session 3. 2 sites reviewed the content in fewer sessions. So we had recommended 3 sessions, but they did it in 2. And therapists who did not attend the learning sessions did report reviewing the guide on their own. This slide shows you that most participants reported reviewing key guide modules and the video, and about 75% reported practicing the 10-meter walk test, and 50% practiced the 6-minute walk test. 84% of the therapists reported using the Iwalk Assess app for a length of time that ranged from 1 to 5 months. This slide is to show you the characteristics of our physical therapists who participated. So in the second column, these were therapists on whom we had chart data or health record data, and shows you that about half of the therapists were aged 30 to 39, and 90%, almost all of them were female, and just over half held a bachelor degree, and that we really had a nice spread in terms of years of clinical experience. And we had at least a fifth of therapists in an outpatient setting. And interestingly, 77% of the therapists reported that they had actually learned the 6-minute walk test during their academic training, but only 28% reported learning about the 10-meter walk test. Then the last column shows you the characteristics of people who did participate in focus groups. So we did have a good number that came out to the focus groups. Now I'm going to give you the primary results based on the chart review. So the results are based on information from 348 hospital visits before we gave the toolkit and 375 hospital visits after. So a very nice sample size. Patient characteristics before in the before group and in the after group were similar. So that's what that slide shows you. So for example, I'm just going back here. The median age was 73 before and after. The percentage of patients who were male was fairly similar, just over half before and after. And we had a similar spread of people across the 3 practice settings. Even in terms of assistance to walk, which is down at the bottom here, people were, the similar number of people required, let's say, assistance to walk, both pre and post. Here are the results for each hospital setting and for each hospital setting. The table presents the percentage of hospital visits in which each walk test was administered at least once, as indicated by a score in the health record. So before the toolkit was provided, the 10-meter walk test was noted in the charts in only 2% of visits in acute care and 16 to 70% of visits in inpatient and outpatient rehab. So here's the numbers I'm looking at for the 10-meter walk test. Post-intervention, use of the 10-meter walk test increased by 7% here in acute care and by 26% in inpatient rehab and 30% in outpatient settings. In acute care, the 6-minute walk test was not used at all but it was used in 24% and 30% of visits in the inpatient and in the outpatient settings. Post-intervention, use of the 6-minute walk test increased by 8% in acute care, 19% in inpatient rehab, and 23% in outpatient settings. In the overall analysis, we did a multivariable analysis that accounted for the fact that the same physio was the therapist for multiple patients. And what we found is that compared to pre-intervention, the odds of using the 10-meter walk test post-intervention was 12 times greater. So basically, the odds ratio here, or sorry, I said 12, but I misspoke. So the odds of using the 10-meter walk test was almost 10 times greater post compared to pre. The odds of using the 6-minute walk test at least once in a hospital visit was 3.5 times greater post-intervention compared to pre. And this was after adjusting for clustering at the provider level, after adjusting for hospital setting, ambulation ability of the patient, and the presence of aphasia and cognitive impairment. We also found significant improvements of the documentation of reference values. Now let me share with you the qualitative results, which of course were very interesting. We had 33 physical therapists across the 9 sites who participated in focus groups, and we interviewed 7 professional leaders or professional practice leaders across 8 sites, because one site did not have a professional practice leader at this time in the study. This slide shows you the results of what's called a realist analysis, and I'm sorry it's complex, but it is a very good summary. So basically what we found is that in acute care, people described acute care, in this box here, as having a lack of space for doing the tests. They described having a lot of hallway traffic, low patient tolerance, that the majority of their patients were non-ambulatory, and they had a brief hospital stay, and that therapy goals relate to basic mobility. So I hope all the acute care therapists who are listening are nodding their heads that this matches their experience in acute care. And then what we have below, what we call CMO, is a context mechanism outcome map. And basically, there were 2 different stories for acute care therapists based on our analysis of the qualitative study. So there was CMO1, so this represents one story here in gray, and CMO2 represents a different experience. So CMO1, in this scenario, the professional leader actually worked off-site or was not available, like there wasn't one. And physical therapists worked in different units across the hospital and treated patients with stroke. Some of them treated patients with stroke infrequently. In their experience, they did not mark permanent walkways, and they had difficulty managing learning sessions. They reported that they did not practice tests with patients, and they also described the tests as irrelevant to their clientele, and they lacked motivation to integrate tests clinically. So what they concluded in the qualitative data collection to us is that the walk tests were not used during the study, and the therapist had no intentions to use them in future. So this was one experience, and these experiences were based on data from multiple hospitals. The next set of boxes tells you a slightly different story that's based on different experiences that therapists had. So in this story, there was a professional leader on site. Physical therapists were familiar with one or both walk tests. The practice leaders actually marked permanent walkways near stroke units and participated in learning sessions with physical therapists. The physical therapists used the app to practice walk tests, and they used the reference values with patients, and they actually observed a benefit of doing the walk tests to the patients. The conclusion was, or the outcome was, that PTs used the walk tests in high-functioning patients during the study, and they had intentions to continue this practice in future. And I just want to make a note that we did hear from a number of therapists that they thought that a patient would have to be able to walk continuously without stopping the entire 6 minutes in order for them to do the test. But I just want to emphasize this is not the case. The 6-minute walk test is designed to allow for let's say, lower levels of intolerance. And patients could, for example, take multiple rests or stop after 2 or 3 minutes, and their score would still be valid. Now I'm going to tell you 2 more stories, and these were stories that happened of experiences at inpatient rehabilitation settings that had outpatient care. And they described their settings as in inpatient that patients were frequently non-ambulatory on admission, and that assessments were longer than in acute care or outpatient settings. The outpatient therapist did say their patients were ambulatory on admission, but that they had a limited number of assessments and that their treatments were only 1 to 3 times per week, and therapy goals targeted advanced balance and mobility. So I hope these descriptions resonate. The first story in these settings was that the practice leader was replaced and the site had human resource challenges during the study. The physical therapist worked in different units, and inpatient stays were described as becoming shorter and the caseloads heavier. In this scenario, the practice leader described a lack of social influence over the therapist. The physical therapist did engage with the guide and the learning sessions, even when it didn't suit their needs. They had, however, differing opinions about the guide content and the utility of the smartphone app. So the outcome in this experience was that PTs who reported using one or both tests before the study did continue using the tests, and others who used none or one of the tests did commit to using them in future with high-functioning patients. So this high-functioning patients is a common element to the previous story. The final set of experiences is CMO4. In this set of experiences, professional leaders were either on or off site, and there were a variety of barriers that they did experience. They talked about lacking space for the walkway. There was a need for quarantine during the study, but there were facilitators in terms of therapists already being familiar with the tests and using them in practice. So there were both barriers and facilitators in these experiences. The professional leader was described as having a central role in organizing the learning sessions. Some had scheduling challenges. The walkway was set up near the stroke unit, and this was an enabler. And the app was described as a facilitator to using the reference values. PTs, in the end, used the walk test during the study to validate treatment, to educate patients, and to set goals. Most of the physios in this experience expressed an intent to use the walk test in future, even those who were not successful in practicing the test during the intervention period. So in summary, findings suggest that physical therapists increased their use of the 10-meter walk test and the 6-minute walk test to a lesser degree, and reference values after we provided the toolkit, and this is based on the chart review results. Based on the qualitative results, the toolkit, the ability to mark walkways near treatment areas, perceived relevance of the test, familiarity, and leadership by the professional leader enabled walk test use. The learning session agendas, the instructions for walkway setup, and the equipment checklist in the Iwalk guide did help the professional leader to prepare for and run the learning sessions. And a quick comparison of test performance to reference values in the app at the point of care was described as facilitating patient education and goal setting. The 6-minute walk test was less likely than the 10-meter test to be used because of the time it took to administer and the perceived inappropriateness of the test for patients who could not walk 6 minutes continuously, despite the fact that we told therapists that they were allowed to give the patients rest and give assistance to walk. The 6-minute walk test protocol with a shorter walkway than 30 meters might help overcome the lack of space that was described as a primary challenge for this test. Given the uncontrolled study design, it is possible that some therapists were administering the tests before we gave the Iwalk Toolkit, but we're just not documenting results at baseline, and that they documented the test more consistently post-intervention. And then finally, I'd like to acknowledge the Canadian Partnership for Stroke Recovery, which funded improvements to the toolkit before its widespread release. So a big thanks to our Iwalk research team, comprised of researchers in Canada as well as in the United States, and thanks to all of our site investigators. And a big thank you to Joanne Howe and Jean Lieu at the Toronto Rehab Institute for facilitating doing the video recording. And so at this point, I just as well like to acknowledge our funders and open up the webinar for questions. Thank you.
Thank you, Nancy. We do have several questions, and so I'll just start by reading them out to you. The first one is regarding the app, and someone is asking, will the results be saved indefinitely until deleted by a therapist?
Yes, in answer to your question, yes, the app does save all results, and they are saved indefinitely. The results are numerical, so they take up very little space on your phone, and they are saved to your phone actually, but they are not identifiable. So yes, they will save all the results. The app will save all the results until you go to the home menu and select to clear all saved results.
Thank you. For the 6-minute walk test, do you adjust the walkway distance via the reduce length icon?
Yes, it is possible in the app when you go to the report that to enter a different walkway distance. So, for example, if at your hospital you don't actually have a 30-meter distance and you currently use a 20-meter distance, then you can enter 20 meters. And you can also change the default setting for walkway distance by going into settings.
Does the 6-minute walk test allow you to save values and identify goals similar to the 10-meter walk test?
Yes, it works exactly the same way.
Okay. And then just further to the previous question about where the data is saved, someone just reconfirming that the data is, or the patient information is saved only on the phone and is not in a cloud or some other format. It's just strictly on the phone. Is that...
Yes, that's a very good question. Yes, it is only saved on the phone. And to tell you the truth, when I envision how this might be used, how the app might be used, I mean, nowadays, hospital departments are purchasing iPads, and an iPad, of course, is not feasible to use with someone with stroke because you need to have hands-free, right? So I would suggest that it could be the hospital that buys a couple of smartphones to enable therapists to use apps as they are becoming more common. And then those phones could be left at the hospital. You can, of course, use your own phone. And as I was saying, the test results are not transmitted to some kind of cloud. They are saved to your phone.
For the 6-minute walk test, the normative value has a maximum age of 80 to 89, but this particular site is working with someone who is older, and the question is the test still reliable and valid?
So that is a very good question. So I think there's two questions there, though. So one is, in the original studies looking at the reliability of the 6-minute walk test, did the study include people with stroke in their 90s? And I would have to check on that because I know that usually there are very few people in their 90s in these types of studies. And I'm now talking about the question related to reliability. So that would be a study of people with stroke where they were looking at the reliability of the 6-minute walk test using the same protocol that we use. In terms of the other question that's being asked about the regression equation, is this question being asked about the 10-meter walk test, Dorothy?
The 6-minute walk.
Oh, the 6-minute walk test, yes. So in the original article, if they were unable to recruit people in their 90s, then what it means is that regression equation is not based on people who are in their 90s. And it means that it might not be 100% accurate to be used in people with their 90s. But I think that I don't think there's any problem in still using the equation because the values will be very close.
Can this tool be used for patients that have not experienced a stroke? As it appears this tool will be very helpful to be used in the community.
Yes, absolutely. For example, all of the reference values are all unrelated to stroke, right? Except for the minimal detectable change. The minimal detectable change value is taken from reliability studies involving people with stroke. But all of the other things, such as crosswalk speed, the normative values, the community distances, all of that information is simply generic. So, for example, if you were working in pulmonary rehab or cardiac rehab and you wanted to do the 6-minute walk test or the 10-meter walk test, you could do them and then have compare the values to the normative values and the community, speeds and distances. That would be appropriate. The only difference would be that the protocols themselves were selected from studies involving people with stroke. So you might want to look up your favorite reliability study in the patient population that you work with to compare the protocols and convince yourself that they are either the same or very similar, and before you use the exact test instructions that we have in the app, because those test instructions they were slightly adapted for people with stroke.
Okay, and then the last question, I believe, is there's a physiotherapist working in the community, seeing clients in their homes, and can sometimes do the 10-meter walk indoors, but can only do the 6-minute walk test outdoors, and was wondering if there was a way to link the app via GPS to actually determine distance over a 6-minute walk.
Oh, well, that's a very good question as well, because that was certainly discussed when we were developing the app. It doesn't have that function now, but we all know that our phones actually have accelerometers in them, and that it would be possible, let's say, to develop an app where, I don't know, maybe the patient could wear it, for example, and then you would let the smartphone actually gather data related to distance or steps, for example. But certainly the Iwalk Assess app was not developed for that purpose, but that could be a future function.
And then we've had one last question slip in, and the question is, are there minimal detectable change values for other populations? Minimum detectable change values for other populations?
Yes, and I'm not an expert in all other populations, but because we did our systematic review in the stroke population, but there should be, and we actually if anybody really wants to know, you can calculate the minimal detectable change value as long as you have reliability data from a reliability study. So it's not that hard to do. But yes, there should be reported minimal detectable change values in other populations that would allow you to compare or to add on to a test performance to know the kind of the error, the range of error in terms of evaluating change.
Right, thank you. I'd like to take this opportunity to thank Dr. Saubak for presenting the webinar today. And I'd also like to take this opportunity to thank you as the attendees for participating. I would ask that you take a few minutes of your time to answer the survey that will appear upon the completion of this webinar. And just to let you know that this webinar has been recorded with permission from Dr. Saubak, and the link will be posted on the Central East Stroke Network website within the next week or so, and we can certainly let you know through your registration information so that you have that link to share with others. So again, thank you to Dr. Saubak and to everyone for joining us today, and I'd like you to enjoy the remainder of your day, and we'll say goodbye at this time. Thank you.
Thanks, everybody.